Hello, welcome everyone. So welcome to our Bring Health at You Lunch Forum, brought to you by UNLV. I'm your hostess and moderator. I'm Dr. Kate Zong. I am a geriatric psychiatrist. I'm the Director of Innovation at the Department of Bring Health at UNLV. We launched the Bring Health at You Lunchtime series in the fall of last year in 2021. So this is a free monthly lunchtime conversation with the doctors, researchers, and expert and faculty member from UNLV to discuss a topic that is important to all of us, Bring Health. On the fourth Wednesday at noon each month, we will be joining by Zoom. Hopefully we can do this in person very soon to talk about how to take care of your brain health, to share with you what's the latest in the Alzheimer's world, and to provide some very practical tips, recommendation on lifestyle and how you can reduce the risk and stay healthy, stay sharp. So feel free to use the chat box with any questions you may have. So in the past, we have talked about exercise and brain health, nutrition and brain health, sleep and brain health, and diabetes and brain health. We learn from the expert the importance of staying active, eating smart, getting good night's sleep, and also the importance of getting the blood sugar under control. So today we will address another very important topic, risk and resilience, and the impact of the social factors on brain health. We have a fantastic panel today. They will be discussing the health disparities, the equity of access to care, the barrier to research, impact of low-income housing on the risk of brain health and Alzheimer's disease for diverse groups such as the ethnic racial minorities, immigrant, sexual and gender minorities, the LGBTQ group. So you will hear from our panel experts, their research, their findings, and some of the very exciting initiatives that we are taking on right here in UNLV in collaboration with many partners nationwide to raise awareness, to narrow the gap, and to reduce the risk. So let's get this. I want to first of all welcome and introduce our panelists. Dr. Samantha Jones is a licensed clinical psychologist with a specialty training in geriatric psychology and neuropsychology. She directs the cognitive aging and neuropsychological equity lab at the Department of Brain Health in UNLV. Dr. Jones studies cognitive aging within diverse groups. Her research area include study disease risk and resilience, advanced cognitive test development, and patient-reported outcome, which she's going to share with you momentarily, and examine the health disparity in research and a clinical treatment area. Her research really aims at improving the prediction, measurement, and diagnosis of cognitive change and neurodegenerative disorders such as Alzheimer's disease. Thank you, Dr. Jones. Our next panelist is Dr. Renee Libro, who is an assistant professor at the Department of Psychology of the College of Liberal Arts at the University of Nevada, Las Vegas. Dr. Libro is the director of community health for minority populations, immigrants, and other newcomers, and their mental health research lab. That's an acronym there. So Dr. Libro is a community-based mental health and well-being of racialized, ethnic, sexual, and gender minority, migrant with or without status, older adults, and people living with or at risk of HIV and AIDS. So welcome. Speaker or panelist is Dr. Jason Flack, who is an assistant professor of the Department of Social and Behavioral Health, School of Public Health at UNLV. Dr. Flack's research focuses on better understanding concerns and needs of diverse people such as LGBTQ living with Alzheimer's disease, Parkinson's disease, as well as their caregivers' health and related needs. Dr. Flack helped to create Building House Las Vegas, a group dedicated to organizing and creating affordable and welcoming housing for LGBTQ community. Dr. Flack's work has been featured in NPR, US News and World Report, Newsweek, as well as the Alzheimer's Association. So welcome, Dr. Flack, and thank you.
Thanks for having me.
So we know that Alzheimer's disease affects a different ethnic group in a very different way. We know that African Americans are about 2 times more likely than the white Americans to have Alzheimer's and other dementia. And similarly for the Hispanic population, they are about 1.5 times more likely than the white to have Alzheimer's and other dementia. And yet, despite the higher rate of Alzheimer's, African American and Hispanic are less likely than white to have the diagnosis of Alzheimer's. The data show that only 30% for the African American and only 18% of the Hispanic are to be diagnosed with the Alzheimer's condition. So Dr. Zhang, I want to actually start with you to help us understand this numbers, this phenomenon, and what does that mean? And how does that impact on the overall care that we can provide to the African American and the Hispanic population?
Great, thanks, Kate, and wonderful introductions of our panelists. Excited to see the other faces today. I think probably a great place to start is just with the idea of how most of our research has traditionally underrepresented these individuals who, as you mentioned, are facing the greatest risk for development of Alzheimer's disease. And so traditionally, when we're thinking about treatment-based studies or like clinical trials research, the prevalence or the participation of ethnoracial minorities tends to be at about less than 5% of all enrolled participants in those clinically focused trials. And then if we're talking about something like an observational study, so something maybe where a treatment isn't even necessarily provided, but participants are just observed over time during the disease progression, that number bumps up to about 9% representation and inclusion of ethnoracial minorities. So both numbers obviously much lower than the Nevada proportions of those groups, and certainly of the United States proportions of those groups. And so for me, when I think about these things, I start from a place of research. And so again, for me, that results in we have a lack of data. We don't have good data to back up our understanding of the different mechanisms that may be at play, the different disease comorbidities that might be at play, and certainly what we'll focus on today, the different social factors that might be influencing the differing levels of risk. And so, yeah, really, I think that one of the best places to start is just an understanding that in terms of representation, our research hasn't done a very good job of including all of these groups.
That's such a striking low number, isn't it? 5% to 9%. And yet, when the research outcome is becoming available, the researchers write papers, and then the companies will produce drug eventually based on a lot of research data. If the groups are so underrepresented, I wonder if you can tell us a little bit what that would impact, because it's so low, the number, right? So that, in terms of when we're thinking about the side effect of the drug or the implication of the research conclusion may not necessarily be accurate in those subgroup of population who were not adequately represented in the study phases.
Yeah, absolutely. So I think, again, as you mentioned, in terms of clinical trials, and in particular where drugs or treatment studies are involved, if we don't have the data to know how individuals are responding to those medications and treatments, then once they do get approval, we have less information to be able to predict the therapeutic response, the therapeutic dose, to really guide our clinical practice guidelines, in fact. And so it really just prolongs the amount of time that it takes to convert what we saw in research into clinical practice, because a lot of the studying ends up happening on the clinical end of the continuum once we start prescribing to patients, rather than being settled earlier in those trial phases.
So it really is so critical, isn't it, for the African American group, for the Hispanic group, and other minority group to be included at the very early on with regard to clinical research, clinical study. Without their participation, without their involvement, that the end outcome of the product will not be adequately representing them.
Right. And I'll just add one other thing, which is, often we use the language of, participation rates being low, when in reality, in most cases, it's actually that access to these studies is also quite low. And so really the onus is on us, it's on the researchers to do a better job of making sure that we're doing inclusive recruitment, that when we're offering treatment-based studies, they aren't solely based at academic institutions or other locations that might be difficult to access via transportation, or that maybe because they're tied to, you need an existing relationship with a physician in order to get enrolled in a trial. And so if you don't already have a good relationship or a partnership with a healthcare facility, you may not even realize that these trials exist, right? And so really the onus is, it's on us to make sure we're doing more inclusive recruitment practices.
Thank you. That's a great point. I think that partially explains why the number is so low, lack of access for one. I would love to actually turn to our next panelist, Jason, to talk a little bit about, from your experience, as to the reasons why that the numbers for the African American and for the Hispanic, in terms of them getting that diagnosis of Alzheimer's, are low, despite a much higher rate of such condition compared to their counterparts in the white population.
Yeah, well, I think that, Dr. John has highlighted a lot of the pieces around that. Often the places where people can go to get access to, right, a dementia screening or a diagnosis process, they're not in their communities. And many members of the communities, especially those that are diverse, I work a lot with LGBTQ plus populations, and many people have experienced discrimination when they've gone into these healthcare settings to receive even everyday care. And so they may be reluctant to seek out care because of those past experiences, fears around things like either being treated unfairly, not including maybe your family members of choice in your care experience, to the point of even, right, where they're not using your name, or they're mispronouncing your name, even though you've corrected them, or they're, misgendering you, or not asking about sort of your experiences and your background and building that into that diagnostic experience. We also know for many people that are experiencing memory problems or dementia, that they may not have the support team to get them there, right? So they may not have a caregiver that could be the informant and talk about the experiences. They may need support around transportation, like Dr. John said, right? Of like, they may not be able to come to some of our academic research centers and get there easily. They may live multiple hours away from actually these regions. And so those create some unique barriers for them. So I think it's compounded by, right, some of the many structural issues that face this, as well as social issues of not feeling welcomed or included. And then we know for many of these groups who have experienced discrimination, whether that's based on race, ethnicity, sexual orientation, or gender identity, that they really don't find the traditional settings very inclusive of their lives, of their experiences, or how they navigate the world. And so they do not want to go and access those services. And then the other piece that we need to be thinking about is many people from these communities have not have access to the same opportunities. So they may not be able to afford the care. That's a huge issue, right? And many of these places do not, help people sort of figure out the financial implications of the care. And so that's a huge barrier as well.
So thank you so much for that. Obviously, there are multiple factors, from what I heard here is from something very concrete, like transportation or lack of which potentially can be resolved relatively easily to lack of access to care, to the physicians, and to more general phenomena in our community of discrimination. So there are so many different factors playing in, which may hinder people to gain access to the healthcare, then can potentially delay them being diagnosed. I think Dr. John will be talking about later on in terms of actually doing the clinical assessment. There is another set of barrier as well. I want to turn table to Dr. Libro for a minute. You have done a lot of work in the community and with a special focus on the immigrant as well as older adults and HIV. So I wonder if you can share with us your experience in those minority group. What kind of experience, what kind of barrier are there for them to reach out to get help?
First of all, thanks, Kate. First of all, I'd like to say the same thing as Dr. John and Dr. Flack about being happy to be part of this panel and to be able to just share with the rest of the people or the folks in this meeting what we've always wanted to talk about, which is, of course, older adults, and then, of course, brain health, especially for those who are having difficulties accessing such services and healthcare in the community. So I was wanting to build on what Dr. John and Dr. Flack mentioned about the fact that, there are many different challenges that are faced by different subpopulations that are underserved and underrepresented: racial and ethnic minorities, LGBTQ folks, people with lower socioeconomic status, newcomers and immigrants, and of course, people who are homeless, right, or are underemployed and unemployed. And all of these different communities and populations have their own unique challenges in how they're able to access not only care, but also participation in the research that Dr. John was talking about earlier, right? So Dr. John mentioned about the fact about the physical access to these things and resources. Dr. Flack just mentioned about the fact that, it's not just physical access also, but the fact that people may not have financial capabilities, or they have financial constraints in accessing them. And I think that these different underserved populations have all of these plus more. And eventually I want to segue into talking about how we're able to kind of figure out how we're going to be able to figure out the other challenges that we may not necessarily know about that are specific to their context, right? Because what Dr. John and Dr. Flack have talked about are things that for the most part researchers know. But then maybe there are certain contexts that maybe we're not aware about, and then maybe potentially I'll eventually talk about segueing into how community engaged research and community-based participatory research is going to be complementary with other kinds of clinical and epidemiological and other empirical research that is being done or are being done by different researchers.
Great. I think that we got a question in terms of how people can sign up. Where can they go if they want to volunteer for clinical research or study? I think that's a great question. Thank you for that. Obviously, it really depending on what kind of research, what kind of study. So I think that our all three panelists here have their own research initiative. So I wonder if Dr. John can start it by sharing with us your research and what kind of participant that you will be looking for, and likely for Dr. Flack and Dr. Libro as well.
Sure. So I would say maybe a lesser known resource for individuals who might just generally be interested in research participation broadly, nationally, regardless of where you're located, is that you can start and look at some search engines that are compiling available studies. So clinicaltrials.gov is a good source if you're looking for treatment-focused kinds of projects. There are multiple different kind of what we call like brain health registries that exist across the country. I know Dr. Flack is a leader of one of those. I myself am a part of a sort of 3-city focused project that is working to build a network of older adults, so 55 and older, of Hispanic or Latino descent, who are interested in participating in aging and Alzheimer's disease research. And then I would say, of course, again, regardless of where you are, look to your local universities. If you happen to be in this call and you are interested in participating in a project, I'm sure you could also throw your email address or contact info in the chat, and probably all three of us would be excited to reach out to you. But right now in my lab, I have a couple projects going on, all focused again on older adults. So typically I say 55 years and older. And for those who are at risk for potential development of a neurodegenerative disease. And I define at risk pretty broadly. So that could be an individual who is maybe experiencing some memory declines that they subjectively feel might be happening. Maybe risk is that they have a family history of a disease. And so we know that because family history can increase one's personal risk for disease, we look at those things. Or potentially individuals who might already have, spoken with a doctor and they're exhibiting some of those early symptoms. I'm looking for the sort of the whole continuum, and I'm looking across ethnoracial groups. So that is one thing folks can do. And again, I know both Dr. Flack and Dr. Labora have projects actively at UNLV as well.
Yeah, so a lot of work that's been coming out of the National Institute on Aging through the National Institutes of Health is focused on and basically bolstering some of the engagement of our diverse communities in Alzheimer's disease research. So there's many places that are developing registries where they're looking to get people engaged, find out about the work. And just by signing up for a registry doesn't mean you have to do the study. It just means that you will get information about these research opportunities, and then you can make a choice if that's aligns with sort of your availability and your current interests. The other one I would really push for is the Alzheimer's Association has something called Trial Match, and I'll put it in the chat. And it's a great way, many studies that are doing work in this space, you can have your study advertised through Trial Match, and then you could sign. It's also like a research registry that you could call or you can email to get started and sign up for it. So there are pieces out there. Some of the challenges is many times when people are looking for something, they want it immediately. And that can be a little harder. So if you're looking for something immediately where they're enrolling participants, you might look either at your local university or look at, your local, if you have an Alzheimer's disease research center in your community, like how we have Cleveland Clinic's Lou Ruvo, then you could contact them to see what kind of studies or opportunities do they currently have available. So there's a lot of resources out there, but it sort of takes, with any study, it has to be sort of the timings right for you. And then for many of the studies, you have to meet certain eligibility criteria to be able to enroll. But there's resources out there, and keep an eye out because more and more are coming. We even just heard recently about Congress passing more funding to support Alzheimer's research. So that means more trials, more research will be coming.
Over $250 million additional funding has been allocated to Alzheimer's research. So that's really great news for the entire community and our society. So I just want to reiterate the importance thank you for people who are interested and wanting to get engaged, wanting to get involved. I think that's a first very important step. And as the doctors have just alluded to, there are obviously all kinds of research. Sometimes the task of finding the right one for you might become a little daunting, frankly. But as you have heard, that registry is a good way. So it's not interventional, and there are many, many out there. You can simply just type in Brain Health Registry. And in the chat box, I think that our panelists have provided quite a few links. And we will be happy to provide additional information after this call. So I want to thank you for that question. Renee, do you have anything to add to the study?
Yeah, I wanted to say that for our parts, like Dr. John, Dr. Flack, and I, we have our own studies and research projects. And we actually, since we partner with different community-based organizations and different community partners, most of our partners also have access to ways to be able to have participants or interested people who want to participate in our studies. And so these are organizations like, the LGBTQ Center of Southern Nevada Health District. So if you're local, the Clinical Counseling Center of Southern Nevada, these are places wherein as part of our effort to reach out to the community, make it more available or accessible to people who might not be able to or may not be in the know about these different studies. So as the other panelists have mentioned, it really depends on what kind of study you're looking for or what kind of study that you might want to be involved in to either volunteer or to participate in. And you can, like Dr. John mentioned, you can always contact us as well. So we're easily available. Any of us are available, and we can just, maybe connect you to what, or at least point you to the right direction as to what we know might be able to, might be accessible for you and might be a good fit for you as well.
Thank you. So I think that's a great segue, talking a little bit more about the access to care, access to research, and access to clinical trial. Dr. Flack, I know that you have done some research with regard to telephone measures. And so that's a great way of reducing the need of transportation. In a sense, people don't have to travel to clinic. And that's also partly in the future, a lot of clinical trials potentially can be done remotely. So could you share with us a little bit about that particular project?
Yeah, sure. So we have a study that's looking at engaging LGBTQ plus people that may be experiencing a memory concern, or they're just wondering how is their memory and thinking, how are they doing? And so we are enrolling participants and doing a cognitive screen over the telephone. So it's the telephone interview for cognitive status. And this has been used a lot by national studies, such as the health and retirement study, to try to get an understanding at the population level. What are we seeing in terms of like cognitive impairment or potential concerns? It is a screening tool, so it wouldn't be something that could help with like a diagnosis. You would have to go probably to meet with a neurologist, or go to one of our Alzheimer's disease research centers or other setting to get that. But they are helpful in kind of giving us an idea if you are sort of, based on this screening, maybe meeting a threshold where you would need a full exam to better understand, is it dementia or could it be due to something else? So that's also a big piece to realize, is that sometimes challenges with memory and thinking could be due to things like stress, lack of sleep, depression. It could be a side effect of maybe a medication you're taking, or maybe you have an underlying illness that you're not aware of, but it's very taxing on your body and could be creating some of these challenges. So the screening will not pick that up. So that's why we're saying often we would want you to go to get a full workup if we're actually seeing you are meeting sort of a threshold for potential cognitive impairment. The other piece to know is, with like the stay-at-home orders and the pandemic, we more and more have been moving to telehealth visits. So there's also a potential that you could meet with a neuropsychologist or someone else that could actually do a full screening battery with you virtually, maybe through Zoom or another type of program. So there are resources out there that community members should know about. That doesn't mean you have to actually go into a clinic or come to our setting to get the assessment. We could actually do it with you virtually. And so that is a unique resource that we definitely need to be promoting more. And that's our hope, is that we can use this to engage people that traditionally wouldn't be able to access it.
I think that's fantastic, Dr. Flack, because this is such a, as we have just alluded to earlier on, a population or group of people who may have very difficult of accessing the healthcare system, and also that they don't have the traditional caretaker, so to speak, to help to provide additional information to the doctors, which is really critically important to really clarify the overall diagnosis. So this is an ongoing effort for people who may have some memory concerns. They can just reach out to you and then go through this telephone's memory screening.
Yes. Yeah.
Okay.
Absolutely.
Maybe you can share that information in the chat box so people can reach out if they have the need. And also that I'm hoping people here can be the messenger to spread the word, so that we are actually providing this type of service to this specific group of population, which is really great for our community. Yeah. Dr. Liberal, you also have some very exciting initiative and research looking at a specific population. Could you share with us on that as well?
So currently I have like 2 research projects ongoing with the community, but the one that's specific for older adults and brain health involves our project about it's very specific people living with HIV and people who may be experiencing what we call HIV-associated neurocognitive disorder. So in this particular project, it's a mixed method study, and we're almost done with our quantitative stage where we've done surveys. But now we're transitioning slowly to our qualitative stage where we're doing interviews, especially people we've already done surveys. So it's more like a continuation. And of course, our quantitative stage has informed the research questions that we've, or the interview guide questions that we've formulated for our interviews. So people who are older than 45, who are living with HIV or have been living with HIV for quite some time, at least a year, and who are residing in Southern Nevada, are welcome to actually participate in this study. We do also have another aspect of this study wherein we have surveys and interviews with service providers. So the service providers, if they're actually working in the HIV/AIDS sector of Southern Nevada, then they're also welcome to participate in the study if they've been working in this sector for more than 6 months, if they're working in Southern Nevada, and it could be social workers, case workers, doctors, HIV specialists who might be working with people living with HIV and who would be willing to participate in our study to help us gain more knowledge or generate more knowledge regarding what people may be aware of. It's about awareness, about critical consciousness. It's about the things that we need to do to eventually raise awareness. It's a kind of a double-edged sword. We're doing the interviews, and at the same time in the interviews and surveys, we provide some information. So it's kind of informational as well about HIV-associated neurocognitive disorder.
I think that's such an important topic because a lot of times people don't think too much about HIV and neurocognitive impairment, but we've seen many patients with HIV and who have experienced a lot of cognitive impairment and times really mimicking dementia, mimicking Alzheimer's to a certain degree. So this is a very important area, understanding their cognitive function, their cognitive change in this special population. So thank you for doing that. And again, this is so much needed for this population, isn't it?
Absolutely, yeah, because actually since the start of combination antiretroviral therapy for HIV, the HIV/AIDS dementia has significantly decreased. It's practically not present anymore, only for those who have not been able to receive care. Continuity of care. But for mild and moderate neurocognitive challenges associated with HIV, it's like more than 40, almost 50% of people living with HIV, even those taking certain medications that have been prescribed, still experience this mild to moderate neurocognitive functioning. And research has shown that these kinds of impairments affect instrumental activities of daily living, and of course, affect the quality of life of people living with HIV despite taking meds. Yeah.
That's great, because I think when people think about a common question we got all the time is what's the difference between dementia and Alzheimer's, isn't it? We talk about dementia as an umbrella concept. It's a syndrome, so many clinical conditions can contribute to dementia. You know, obviously Alzheimer's is one of the most common type of dementia, but in this case, HIV dementia as well, and Parkinson dementia and post-stroke dementia, vascular dementia, there are all kinds of dementia. So I think that there are a lot of commonality among those patient population who experience the neurocognitive impairment, regardless of the two underlying causes. So Dr. Zhang, you have done a lot of neurocog assessment. And you know, this is what we talk about, a lot of paper and pencil, and this is how we really do the evaluation to diagnose patients. Please share with us what you do and how can people help in that regard.
Sure. So Dr. Flack mentioned earlier this idea of a screening instrument, so something that might be able to be performed or administered over the telephone. What we do sort of following a screening instrument, if it looks as though someone on a screen is exhibiting issues in cognition, what we like to do, or rather what neuropsychologists like to do, is to administer a more in-depth set of tests that can really help parse out potential etiologies or potential causes of those ability, cognitive, and memory kinds of changes. And what we do is we have tests that are created really to tap into different kinds of cognitive domains. So memory is the big one, and the one we're probably all most familiar with. So we have tests that are devoted to memory. We also have tests that are devoted to abilities like language, to visual spatial skills and visual spatial reasoning. We also have tests that tap into executive functions. which is just our big word way of describing some of our higher order thinking skills. So things like reasoning, judgment, our ability to multitask or switch between different tasks during the day. So we have tests that are devoted to each of those cognitive domains. And then really we evaluate the performance across that entire battery of tests to help inform both how significant the impairment or change in cognition might be, as well as what the potential cause or etiology might be. And so you've heard the other folks reference a few of the potential etiologies. Alzheimer's disease is certainly the most prevalent, the most common etiology of a cognitive decline among older adults, but things like stroke, we've mentioned things like HIV, things sometimes even like depression can mimic some of these same symptoms. And so through a more in-depth evaluation, we're really able to sort of better identify what the potential and likely cause could be.
So it sounds like obviously it requires quite a bit of language skill in order to complete such neurocognitive assessment. So we have heard from our panelists, people who, for example, immigrant whose first language is not English, or who only have grade 5 education. How would you actually help those people to go through this neurocognitive assessment process?
Yeah, so you've identified one of the biggest issues with neuropsychological assessment, which is by and large, it is not a very inclusive or accessible set of tests. And so traditionally, the majority of our measures were developed and then validated on samples that were primarily non-Hispanic white, English-speaking samples that had 12 years or in many cases much more education, and oftentimes who come from higher socioeconomic status levels. And so the tests themselves were essentially not created to be inclusive, and certainly not to address, as you mentioned, different languages or folks who might be bi or multilingual. And so I'd say about the past 20, but certainly the past 10 and even more so in the past 5 years, there's been a move in the field of neuropsychology to make the tests themselves more inclusive and accessible. There are now some batteries that have been entirely translated into different languages. And so that's a huge improvement and step up. Of course, that also requires that you can find a provider who can administer the tests in your first or native language, right? Because as you mentioned, even if someone is maybe bilingual or multilingual, we're more likely to sort of think in terms of our native language or our first learned language. Yeah, and so performance on tests can often look as though the bilingual or multilingual speaker is delayed in responding, but it's really because they're doing sort of twice the amount of work as the single language speaker is doing on the same test. So if you find yourself in that position of being a bilingual or multilingual speaker, hopefully find a provider who can offer you services in your language, or at least a provider who is aware of the sort of cultural influence on performance.
I think that can partially explain again why the Hispanic population, African American, actually have a much lower rate of being diagnosed if there are cultural issues, language issues that would actually prohibit them from even going through such important tests. Obviously, they will not be properly diagnosed, right? So I think that really talked about importance of inclusive and how the assessment can be done or created and built, which can meet the needs of people of all cultural background, all languages. that I know that there has been a lot of computerized assessment using cards, so it's language independent, so you really look at the numbers and the colors and all that. So I think there has been some development in that area. Hopefully that in the future, this could be a global or universal way of diagnosing cognitive impairment regardless of any background. So I think that would be great. Dr. Flack, you have spent quite a bit of time working on the helping with low-income housing issue. I wonder if you can share with us a bit your experience, how the low-income population as a social factor impact on their overall brain health and mental health and their overall well-being.
Yeah. So a lot of research is starting to bring forward that we know like social determinants of health is connected, right? It's whole body health, but it impacts the brain. And we know, for instance, it's experiencing economic disparities impact, right? Your ability to access preventative screenings, to maybe be able to purchase the most nutritious foods, or even many people have to skip or take medications every other day because they can't afford to take the medications regularly, right? And then that may impact, and they don't tell their healthcare providers about that. And then that may affect the efficacy of the drugs. So what we're finding among low-income LGBTQ plus seniors is that about 1 in 4 are sort of meeting a threshold of potentially having cognitive impairment. Again, this is right, it doesn't mean they have dementia. This is based on sort of doing the telephone interview for cognitive status. And so we would recommend, right, that people get a full screening. But we are seeing, right, a lot of concerns for people that are living in low income environments or living, on a very low income. This is people that are living in a place where you may need to make like $50,000 to $80,000 to be considered not in poverty, and many people are living on less than $20,000 a year. So very poor, right? And so that impacts their access of many resources, their access to healthcare. They may not be able to afford some of this specialized healthcare if, for instance, they're on Medicaid and Medicare, and it won't support that. So it creates some unique challenges, and we think it's linked to both life course aspects, but also current everyday experiences. Living in poverty is very stressful and harmful to health. And so those are really what we believe are linked with brain health as well.
Thanks for sharing. I think that's very consistent with what we have talked about before. That is the modifiable risk factors in terms of lifestyle. We understand, depression, for example, lack of sleep, a high stress level, diabetes in particular has a very high risk for people who develop later on Alzheimer's. And we know people who have low socioeconomic status, maybe they don't have enough adequate financial means to eat healthy, and then therefore the obesity and diabetes have been very prevalent in that particular population. That's really increased the risk for dementia. I think they become all full cycle in terms of how that the lower economic status exacerbate their health condition and then increase the risk for dementia. But at the same time, I think one of the silver lining in this is that those can be changed, right? So when they start to eat healthier, when their economic status is improved, when they have adequate housing provided by, Dr. Flack and your team helping them to resolve a lot of housing issue, and then their cognitive function can be improved. So I think that I just want to share with our audience, so there are some good news, so that there are ways we can do to help to improve, to reduce the risk, and also to really bridge the gap. And I think that's what we're doing here. So thank you for that. Dr. Liebert, you have talked about the research that you're doing. You use a term that is a community engaged, a community-based participatory research. I know a lot of people probably are not familiar with that term. Can you share with us what you do?
Yeah, sure, of course. Before I answer that question, I just wanted to add on and build on to what you and Dr. John and Dr. Flack have mentioned earlier about the importance of knowing all these etiologies and possible reasons why people develop cognitive function problems or cognitive issues. The fact that I wanted to kind of connect for some people, at least, if not all people, how it works, why diet and exercise are important is because not having the proper diet and not having the proper exercise actually leads to a lot of comorbidities that you've mentioned, like diabetes. I, for one, I'm diabetic myself. I have a high cholesterol, right? And all of these things, if you don't have nutrition, if you don't have medications for it, what will happen is you increase your risk for not only other comorbidities like obesity, but they all come together and increase the cholesterol, low the LDLs, or the low density lipoproteins that build in your vascular system and eventually affect your brain, right? So how this works is it affects people through vascular dementia. And so vascular dementia is one of the more ignored or neglected causes of dementia of older adults. And if you have a proper diet and you can stave off these, and if you have enough, like Dr. Flack has mentioned, access to medications that keep your cholesterol low, these are things that are very preventable that not a lot of people have access to, or this knowledge. And if they only knew, then, even if they didn't have a lot of resources, basic things that people are unaware of that can be addressed, can be done through these social determinants of health. To answer your question about community-based participatory research, I mean, most researchers have had at some point or another opportunities to do community engaged work. Just to answer community-based participatory research, it's not, many people have an idea that it's just about community, involving the community, right? Having them, engaging them. And that's partly it, because community-based participatory research is an approach that is like a continuum, right? Or a spectrum, or however we want to call it, on the different levels of involvement of community partners, right? You have community partners, collaborators, supporters, you call them different names from stakeholders from the community. But the basic idea that maybe I'd like to share with the group is that community-based participatory research, what makes it different from other types of community engaged, community involved research, is that the primary focus is for social change, right? It's for empowerment, right? And so having community partners become involved, because we mentioned that, research has traditionally has not been created through the lens and the focus of the community. Some of us are aware of the fact that back in the 50s and the 60s, we call it helicopter research, where researchers come from somewhere and go to the reserve and then on a helicopter and do what they want, take blood, and not even after doing everything the research, they just leave and have no involvement. They just take what they want from the community, right? And so we need to we've moved beyond that, but we can move forward and more beyond that by having them involved in all aspects of research, or all stages of research. I'm talking about they meaning the community, right? In the sense that from building or creating the research question that is most relevant to them, all the way up to the end wherein they're part of the knowledge mobilization, knowledge translation products and platforms, so that they have an idea, they have the genuine feeling that they're meaningfully involved, right?
So the empowerment is critical, the participation is important. And then also we have been talking about the patient-centric approach. It's all about the patient, right? So I think that there are a lot of research right now going into the community, going into where a patient lives, and then to get them actively engaged. And then they play a very important role. They have such a powerful role and such a powerful voice. That's something that we want to respect, and that's something we want to share, and we want to utilize that to help us to advance research and ultimately to benefit our patients. I think that's such an important point that we have talked about. We only have a few minutes left. I know that we can carry on the discussion for a long time. And I'm just going to ask each of our panelists to have one take-home message for our group based on our discussion today. Obviously, we cover a very broad area, talking about the high-risk group, talk about the lack of access, and talk about what they potentially can do. And also thanks to all of you who share with us a lot of effort and initiative you are engaging with the effort of reducing the risk and also narrowing the gap and address this issue. So I want to thank you for all you do. So I'm gonna then start by asking Dr. John to give our group a final take-home message, not more than 1 minute.
Fair enough, I'll be quick. I'll say to expand on Dr. Laboro's point about, empowerment, right? We've been talking about a lot of seemingly negative sounding risk factors, but on the lens of empowering participants, to the extent that we can increase the inclusivity and diversity of our research studies, not only are we hopefully empowering individuals to get involved, but they're really empowering us and our research. They're improving clinical care to a wider swath of the population by giving us their knowledge, their expertise as what their experience as a patient is like. And so for me, that's part of the drive. That's part of my interest in doing the work.
Thank you, Dr. John. Dr. Flack?
Sure. So I think the big piece is, first, I agree with Dr. John. Our communities are very resilient. They know about resources. They know how to leverage the strengths and the unique pieces that their communities hold. And so we need to be leveraging those, empowering, but also sharing the resources that we have so they can share those back. And then finally, we need to ask some of these meaningful questions. So in my work, I always advocate, we need to ask about sexual orientation and gender identity in our work. If we want to understand the needs of our diverse communities, we need to make sure that they're represented in the questions that we're asking so that they can be included and we can make sure that the research is designed for them. And so really that's a key piece I hope that we take away today.
Great point. Great point. Dr. Libero.
I just wanted to echo both what Jason and Sam said earlier, that the onus is on researchers, scholars, scientists, right? We should know better, having had been educated and trained, and so we have to leverage, as Jason mentioned, what the community has in their strengths and increase their capacity. And most importantly, I think that we should be aware of the fact that community stakeholders can be given different opportunities to participate meaningfully. Often we think about them as sources of participant recruitment, as participants. We can also have them as members of our community board, members of our research team, and also potentially peer researchers, right? Once they get enough training and education added onto their own lived experiences and expertise as people who have that epistemic privilege of having all these factors that we're trying to assess and evaluate, then eventually they can participate more meaningfully if we give them, if we provide more opportunities for different community members to participate in our work.
What a diverse discussion we have, a diverse group. We touched upon Hispanic, African American. We talked about the LGBTQ, the immigrant, the HIV group, and obviously the elderly. I think thank you for sharing with us your wisdom, the knowledge. We not only heard about the risk, but also I think more importantly, the resilience of what this group have. I mean, one thing we didn't really talk too much about is how the Hispanic and the African American culture have more social connection, the family value, how they respect the elderly. Those are very important protective factor. So thank you all. And I want to share with all our group that our next monthly series is going to be on April 27th, last Wednesday of April. We will be talking about women and brain health. And one of our guest speakers will be a physician from Cleveland Clinic, Dr. Jessica Coatwell. And so I hope you all can join us, and that will be for sure another very important and interesting discussion. So I want to thank you all. Feel free to send questions to our panelists, and I thank you very much for your participation. Have a very good Wednesday. Thank you.
Thanks, everybody.
Thanks.
Thank you.